I'm Dr. Geyser from Rustenberg Femme Fertility Clinic. We are talking about PCOS, and today is our part 3 presentation on this topic. We are talking about options for conceiving naturally, ovulation induction and IVF. So in our previous talks, we talked about the diagnosis of PCOS, the long-term consequences and the risks, and ideally all of these have to be addressed before we attend to fertility problems. So the chances of conceiving naturally in infertility, maybe we should first then just review on what is infertility or subfertility. According to the World Health Organization, it is the unprotected intercourse by patients actively trying to conceive for at least 12 months. The exception is then patients who are older than 35 years of age, which when we talk about 6 months, and patients that have gynecologic complaints like painful menstruation, irregular cycles, pain with intercourse. These patients we will start to investigate earlier. It's also important to remember that it takes two to tango, and we should not forget about the man. Men are also involved, and they should at least have a semen analysis. 50% of fertility-related problems are female-related, at least 30% or up to 30%. Men are responsible for the issues, and in 20% there might be a combination of female and male factors. So most patients that present to us with PCOS usually present with fertility-related complaints. As we explained earlier, up to 80% of these patients are overweight or have a BMI of more than 25. According to the World Health Organization, patients with a BMI of more than 25 are classified as overweight. If your BMI is more than 30, you are classified as obese. These patients then also usually present with irregular cycles, and often they have excess of male hormone, which we call hyperandrogenism, and they present with acne, and they might also have abnormal hair in the male distribution pattern. Now, what is your chances to conceive normally? Yes, you can conceive normally if you have intercourse at the right time when you're ovulating. These patients might conceive, but it might be unpredictable, difficult to know when ovulation occurs, and these patients are often also not ovulating. So we use a stepwise approach to patients with PCOS. The first line is always lifestyle and weight loss. If you manage to lose weight, 10% of your body weight, many of these patients will start ovulating spontaneously, and their cycles might regulate. But we know how difficult it is to lose weight, and really most patients don't manage to lose weight on their own, and often patients will tell you that they've tried all sorts of diets, and they eat all the right stuff, but they are unable to lose weight. The approach to these patients should be a multidisciplinary one that involves a dietitian, ideally also biokinetics with exercise, because this is also important in the management of these patients, and psychotherapy is also important in the approach to losing weight and changing lifestyles. Also, drugs that we can use to aid in weight loss. The most common one that we use is orlistat, that has the most long-term studies on that, and then also the GLP-1 agonists, liraglutide, that has been shown to be very effective. It involves injections that should be done on a daily basis. The problem with these drugs are that if you stop these drugs, you will just pick up the weight again. It has to be used long term, and the safety has not been proven in pregnancy, so it cannot be used once you are pregnant. And the medical aid usually don't fund these drugs. The injections are also expensive. Then talking about first line, so lifestyle, losing weight, and then part of lifestyle would be drugs that we use for ovulation induction. So the first one is metformin, which is an insulin sensitizer. We know that hyperinsulinemia is part of the pathophysiology in PCOS, and the patients that might benefit from it alone would be your obese patients with a BMI over 30, but metformin on its own is not specifically indicated for ovulation induction in PCOS. We also use anti-estrogens, namely clomiphene citrate, which works centrally to enhance the hormones that induce ovulation. When these anti-estrogens are not effective on its own, we often combine it with metformin. The combination of these two drugs are comparable to the aromatase inhibitors. The aromatase inhibitors, namely letrozole, is now regarded as the first line option for ovulation induction in PCOS. It has a better ovulation rate, and it has a less risk for multiple pregnancies. It does not have the negative effect on the endometrial receptivity and the cervical mucus. None of these drugs are registered by the FDA for use for ovulation induction, and patients should be aware of this. However, there hasn't been shown any risk of abnormalities associated with it. The important thing about ovulation induction is that these patients will need to be monitored for their follicle development, and it might involve multiple scans. It is bad practice to just dish out these medication to patients and tell them to go and try on their own. And we have seen patients that come back with triplets, for instance, with using some of these drugs. So the importance of this is to prevent multiple pregnancy and also to get the exact timing of ovulation right, and we can do that by monitoring them with ultrasound. And then also we help patients and show them how to use urinary LH ovulation kits, and when patients visit our clinic, we train them how to use this to aid them in timing their ovulation. Many of these patients will get pregnant at this point before we have to go further. Now, our second line drugs, many of our patients will get pregnant before we get to this point. So second line drugs, we use this if the above is not successful. The next one that we will use is gonadotropins, which is FSH, LH combination injections. It should be used in a low step-up dose regime. It is more effective than the oral medication, however, it is quite expensive. There is a real risk for multiple pregnancies and also a risk for ovarian hyperstimulation syndrome, or OHSS, which is a serious condition, and these patients can get quite ill. There is a specific protocol to follow and monitor the follicles. The idea is to just get one single follicle to get pregnant. And due to the costs and the risk involved with these drugs, it should best be left in the hand of a fertility specialist. The alternative, which has been shown to be as effective in terms of ovulation induction, is laparoscopic ovarian drilling. That is a process where we do laparoscopy. We drill approximately 4 holes in each ovary with electrodiathermy, and it is also effective. There is no risk of ovarian hyperstimulation syndrome, and it also doesn't carry the risk of multiple pregnancies. The problem is that this is a theatre procedure, and it should be done in accordance with the guidelines to limit the risk for ovarian damage and also for adhesion formation. Our third line approach would be then IVF, which is the most effective intervention. It involves ovulation hyperstimulation, where multiple follicles, the idea is that multiple follicles will develop. It involves multiple injections. There is repeated follow-up visits and scans involved. It is a costly procedure. The eggs are aspirated in the fertility lab under sedation, and then the eggs are fertilized with the male's sperm. Embryos are cultured in the incubators and then transferred into the uterus. As I mentioned, this is a costly procedure, but the success rates are generally very good. Now, our next question is, will PCOS affect the outcome of IVF? IVF are more risky due to the risk of ovarian hyperstimulation syndrome, and specific protocols limit the risk of OHSS in terms of the types of drug that we use and the dosages that we use. We also monitor the number of eggs and the estrogen levels. Generally, when more than 20 eggs are expected, we will follow a freeze-all strategy and transfer the eggs in, or the embryos, in a later cycle. Pregnancy risk in PCOS. Women that need ovulation induction carries a higher risk for early pregnancy loss. Luteal phase defect is caused due to multiple follicles, and we can overcome this process by progesterone support up to 10 weeks of pregnancy. PCOS have a higher risk for these complications, and in IVF it is more of an issue than in where we use the oral medication. PCOS has a higher risk for complications in pregnancy, and that usually relates to obesity, hypertension in these patients, and then also there's a higher incidence of diabetes in our PCOS patients. The risk for congenital abnormalities are not higher than compared to other women undergoing IVF. Then this concludes our part 3 of the PCOS talk. I hope that we managed to give you some insight into PCOS as a condition, and the take-home message would be that there are challenges, but generally there's a good chance for a successful pregnancy. Thank you.